در واقع دپارتمان نوروساینس این دانشگاه هم هستند و مدیر گروه دپارتمان نوروساینس دانشکده علوم فناوری‌های نوین پزشکی. ایشون در رابطه با Fragile X syndrome from neurogenetics behavior standpoint 15 دقیقه در واقع صحبت می‌فرمایند.
Thank you very much. It's really nice to be here. And after all these sophisticated and upscale talks and with all, very elegant data shared, it's really not easy to share even more. But anyhow, there is something for certain. There is huge capacity of doing continued research in the field of autism and Fragile X. No doubt about it. So for me, as a medical doctor, when I did my PhD in neuroscience, and it was back in 2007, it was the first time that was literally encountered a patient with Fragile X syndrome. Actually, the case was initially diagnosed with autistic spectrum disorder. And he came to our clinic, and he was an albino 7-year-old case with neurocognitive decline and with some behavioral challenges. So when we're doing the tests, all of a sudden, he brought something like a test, autism repetition, Fragile X repetition test. So it turns out that he got more than 200 CGG repeats. And that was the first time I got, I became familiar with the concept of Fragile X genetic testing. And as beautifully outlined by the earlier speakers, this is really a very important, approach in terms of figuring out the genetic background of the intellectual disabilities. So when we have the autistic spectrum disorder cases, maybe 2 to 7% of those cases, according to the literature, have the risk of being afflicted with a Fragile X. And from the other way around, when we have Fragile X syndrome, 30% of those cases might at some ways experience symptoms and diagnostic criteria of ASD. So we did sort of IEP or individual educational program for the guy whose name was Reza, and he started to receive some specific kind of individualized approach. And by time, he started to gain. And for me as a PhD student, it was to my interest that I was kind of, we need to do some more research and some more investigation about the cognitive and behavioral background and infrastructures which need to get even better. So by that, my focus at that time was not intellectual disabilities, learning disabilities, ADHD, or autistic spectrum disorder. I was specializing in sleep, and I was doing sleep epilepsy in particular. So by time, it got me to think that I need to dig into the behavioral aspects of these people when it comes into links, into relations with sleep bioparameters. So after I did my clinical fellowship in sleep disorder, and when we started our behavioral sleep disorder unit, and also a laboratory at a hospital, and also at our department, then fortunately we got this infrastructure to dig and tap into the behavioral and sleep-related symptoms when it comes to autism and Fragile X syndrome. So, two requests. First, I'm going to continue in English, number one. Number two is that I'm going to skip many slides because they've already been touched by earlier speakers. I'm not going to take much of your time. These are known. But the whole concept is, as already stated, is this. We have polymorphism and we have hypermethylation of a specific part of a gene called FMR. FMR1 has been hypermethylated in the exon 1 untranslated portion of the long arm of the X chromosome, as you already know. And this translates to some changes and to some disequilibriums in terms of the protein trafficking and also synaptic protein genesis. Also, we have the synaptic plasticity, which is being kind of afflicted in these cases of Fragile X syndrome. When it comes to electron microscopy, it's been shown that the morphology of the dendritic spine is changed somehow in the Fragile X syndrome cases as compared to healthy controls. They have more bulbous head and narrow neck or thin neck synaptic spines or dendritic spines, and that relates to, in some ways, to some kind of behavioral and cognitive consequences. They got problem, mild cognitive decline, or they have some problem in terms of intelligence. They have mild to moderate mental retardation, as you know. So they got problem with attention, mainly. They have problem with learning, memory, executive functions, language. They have problem with decision-making, reasoning, planning, and so on and so forth. So these are all related to this CGG repeats when they are less than 45. So we got normal phenotype. When we have something intermediate level, we have some carriers or pre-mutation state. And when we have full mutation or CGG repeats more than 200, then the symptoms will start to show up. So why we're here? That's a critical question. The answer is probably that I and maybe some of us do not know much about Fragile X. So, and it's been shown by a study done by Brenda Fuenskane that was done in Pennsylvania in 2013. They showed that when they were asking the people who are professionals or paraprofessionals in terms of child care, and would asking them how often, and have you ever worked with a client diagnosed with Fragile X syndrome? It was 50-50. 50% of the subjects in the study didn't have a chance to be working with a Fragile X case. And when they were asking, what is your knowledge and at what level your overall knowledge is about the Fragile X, only 2%. Maybe you guys here. Only 2% of the whole population said that we are so knowledgeable. And more than 95% of the people said that we're almost somehow or we're not knowledgeable. So that's why we need to work on it. Many hospitals, many academic programs around the globe, they have programs to identify, to introduce, and to take autism research and Fragile X research to the next level. So they got high-risk infant follow-up program, craniofacial program, genetic program, sleep program, and behavioral neurodevelopmental programs, and in nutshell, Fragile X program. So for genetic testing, we all know about the details, we know about the prevalence, and something is also important, it's not been touched so far, and that's the genetic anticipation. It takes somehow 3 generations that when someone is diagnosed with a gray zone Fragile X genotype or like a carrier, it takes 3 generations that a full Fragile X guy will be infected. So the prevalence has already been discussed. And developmental characteristics. They have cognitive delays, they have speech delays, they have gross and fine motor delays. So the role of occupational therapists and the role of physical therapists are very pivotal right here. And they also have social emotional delays. They have delayed adaptive behavior. In terms of behavioral characteristics, according to the DSM-5, the first and most important things which comes at the top of the list is anxiety and hyperarousal, which has been stressed by the earlier speakers. So what is hyperarousal? Actually, and they have some overlaps with the ADHD and autistic spectrum disorder symptoms. Hyperarousal or hypervigilance is a very, very crucial kind of the behavioral character. Behind it and beside it, they have hand flapping, they had hand biting. They also may present with some scars on their knuckles, and also they have emotional tantrums, gaze aversion, and difficulty relating to others. So in terms of hyperarousal, the thing is that they have processing demand, which has been increasingly high. So the sensory environment, social interaction, and internal processing load for cognition, language, and executive function has been totally changed. I borrow this from Dr. Hageman. So the Fragile X neurobiology, it's all about that, sympathetic hyperarousal. So we can test it with the sweat test, with the galvanic skin conductance test. Also, we have the GABA inhibitory system, which has been underacted. So this GABA upregulation, downregulation, and glutamate upregulation, and this change in the whole dynamics of the neural transmission system plays a role in their behavioral output actually, and they have this hyperconnectivity of the amygdala hippocampal area with the prefrontal area. So when we're talking about the ventromedial prefrontal cortex and the amygdala hippocampal area, the hyperconnectivity of these areas has been documented in the literature when it comes to DTI or functional neuroimaging. And these will relate to avoidance, social anxiety, selective mutism, aggression, and ASD-like symptoms. And that all rests upon anxiety and hyperarousal. So for the assessment, so what we have, we are running a neuroscience laboratory in Shiraz University of Medical Science, and that's actually a brain cognition and behavior platform. So this constitutes of several, desks. So we have different setups, and the setup is based on the cognitive assessments, behavioral assessments. Also, we have brain and electrophysiology and clinical neuroscience section. So putting them all together into perspective, there is a sort of a platform called Integrated Neurocognitive Rehabilitation Platform. So we have all different setups like the computer, media-rich computer programs. We had all the QEEG, like the electro-neuroimaging. We have the virtual reality. We have the EEG setup. Also, we have the optic and auditory or acoustic perceptual tasks. And we have different sort of neurobehavioral and psychometric assessments. And when we're obtaining some sort of electrophysiological data, in some instances we'll put them into more analysis. Maybe in some instances we're using the FNIRS, which is functional near infrared spectroscopy, and that gives very, very dependable data in terms of the brain hemodynamics and how oxygen and oxyhemoglobin and deoxyhemoglobin being exchanged, and they have specific dynamics when a subject is involved in a specific neurocognitive task, and that's really tantalizing. So also we have the QEEG setup, and we may go for some more signal processing using the wavelet setup. Also we have the functional MRI and DTI, and we have the electrical neurostimulation, transcortical transcranial electrical neurostimulation. The best thing that we use it in daily basis is the quantitative EEG, that we're using the brain mapping, and then we're putting the all electrophysiologic data in terms of decision making. So what we need to do is to first identify whether these guys are doing properly in terms of their cognitive functions, number one, and number two, are they behaviorally sound or not? And one of the constructs of the behavior is their sleep, the thing I adore. So what we have is that we have a behavioral sleep lab, so we get these people have an afternoon nap at our laboratory. So before they get a chance of having an afternoon lab, we're doing some tests, and we're just letting them learn about some cognitive tasks. So the data acquisition is being completed. Some people will be given a chance of having an afternoon sleep, and we do the whole setup of electrophysiological recording, which is typically known as polysomnography. So we do the whole setup of the EEG, EOG, and the breathing, and also we have the chest and abdominal movement. We have the sensors being placed on the surface muscles on the leg, and also the hands. Also we have the oxygen level, the echocardiogram, and everything. So 18 different sensors are being hooked up to the case, and then we have the chance to deep dive into the electrophysiological data. So, and then we kind of relate the electrophysiological data from the sleep test to cognitive tests. So those who had a chance of going down to afternoon sleep would presumably do better when they are retested after their nap. And those who didn't get a chance of sleep may not. So if it holds true, then we're going to find a correlation between the sleep signals and the neurocognitive performance. And the problem is, many of the cases with Fragile X and ASD who comes to our door, they are drastically suffering from sleeplessness. So they got this problem with insomnia, they have problem with hyperarousal, so the arousability index is sky high. They are not going to have a chance of experiencing deep stage of sleep like N3 or N2. The level of their sleep spindles or K complexes is uncomparable to the healthy control, and these are all giving us the whole sense that at some levels sleep bioparameters are closely correlated to their behavioral outcome. And what are the neurocognitive constructs being impacted or being affected by these behavioral underpinnings? We don't know. We need to get it tested. And some areas of cognitive performance turn to be good. You know, as you know, the Fragile X syndrome people, they have very good long-term memory, especially when it's associated with a high interest. When we are nurturing their affinity, then they have a better chance of remembering long-term events from long past. So this is the area that they are doing very fine in. But do we have a ceiling for that? Can they get even better? So yes. Probably what we need to do is to go for cognitive empowerment or cognitive enhancement in those areas that they are pretty much doing fine already. Also, they are good at verbal and visual association for learning and visual discrimination. Some areas in those cases that we've so far, not in Fragile X, but in autistic syndrome, ASD, we have found that they are not doing really well are the cognitive shifting. They don't have this flexibility in terms of cognitive decision making, and so they don't have cognitive flexibility. And they have problem in Wisconsin card sorting test, which is a psychological test being used for assessment of the cognitive flexibility. So they have problem with that. Sustained and selective attention. Maybe that represents their anxiety at some level. And they have many interesting stuff about that. So when it comes to sleep, many nice tantalizing hypotheses will come up. So how can we help them recover their sleep problem? And if we can succeed, help them with their sleep problem, can they even get a chance of having a better performance in terms of their cognitive capacity? Number two, if they have some problem with their sleep, would psychopharmacology help? Is there any specific drug which decreases like GABA agonists? Is there any specific drugs like CBD? Any specific drugs which help to increase their GABA tone and to help, or maybe mGlu-R antagonists or whatsoever, to help them decrease the level of arousability during sleep. And melatonin, sure, I got like 1 minute. And melatonin, do I have 1 minute? 2 minutes, great. So I got one more minute. All right. So the melatonin intervention is really good. So what we're doing is to go for the neuroplasticity and neuroprotective effects of melatonin, number one. And the other thing is that many of the autistic spectrum disorder cases and Fragile X syndrome subjects, they drastically suffer from sleep phase disorder. So some of them are cases of advanced sleep phase disorder. They sleep early, wake up early. Some of them are late or delayed sleep phase disorder. They sleep late, wake up late. And some of them have fragmented, irregular sleep-wake pattern. So at some level, as you're pretty much aware, this relates to the decreased level of melatonin or sleep hormone, which is secreted from the pineal gland in the brain. So the question is, do we need to replace this as a medication? Does it help? And this is a hypothesis. So probably we're going to give it a try and test whether it works or how. And somehow we can give them some wristbands that they are used for a couple of weeks, and that like plots their pattern of sleep and wake pattern. So it shows us at what sleep phase dynamics they're having, they're enough sleep or how. And also if they have some pain, we have specific questionnaire which has been developed by our colleagues in London, and that's by Cerebra. So it's a specific questionnaire which determines if they're at any level suffering from physical pain during sleep. So if there is a problem with that, we need to tap into it. Also, we give them sleep diaries for 2 weeks to make sure that everything is being well recorded. And last but not least, it's not a one-man show job. It's like a two-way street. So we need to work together and together and together. So it's like a multidisciplinary approach. Practitioners, families, doctors, paraprofessionals, and who else who has a role in this need to get involved. Alliance, attitude, and approach. And that is all I just wanted to talk about. Thank you so much indeed.